Hi, everyone. Thank you for joining. We're going to wait a couple minutes here, give folks a chance to hop on. All right, I see some more people hopping on. Thank you for joining. We're going to give it a couple minutes and then Dr. Magaña, Sandy will get us started.
I think I could probably get started.
Yeah, let's go ahead.
Okay. Hi everybody. Welcome back to the Autism Consortium of Texas. And today we have Laura Friedman presenting to us, and she's an assistant professor in the Department of Speech, Language, and Hearing and Sciences here at UT Austin. This is her first year here, and Dr. Friedman earned her BA in Hearing and Speech Sciences from the University of Maryland and her master's and PhD in Communication Science and Disorders from the University of Wisconsin-Madison. Um, where she trained at the Weizmann Center. And she then completed an NIH postdoctoral fellowship at the University of South Carolina. And she's also a speech language pathologist, licensed language pathologist, I should say. And her research focuses on language abilities of adolescents and adults with intellectual and developmental disabilities, and with a focus on Fragile X syndrome and autism. She investigates how language can contribute to key adult outcomes such as building friendships, finding meaningful employment, and developing self-advocacy skills. Her work uses a systems-based approach, looking at how genetics, environment, and lived experience interact with to influence outcomes across adulthood. So with that, I'll turn it over to Dr. Friedman.
Thank you, Dr. Magaña. I'm really excited to be talking to you all today about my research. Specifically, I'm going to talk about cognitive linguistic difficulties associated with autism across the lifespan. So today's learning objectives are to understand the role of language across the lifespan in autism, recognize the broader impact of family context on outcomes, and identify future research directions in aging and neurodevelopmental disorders. So I'll start out with some background information, and then I'm going to present data on language in adolescents, adults, and also first-degree relatives of autistic individuals. And I'll also be presenting some preliminary data from my F32, which focused on cognitive aging in mothers of autistic children. So families report that the transition time from adolescence to adulthood is a particularly stressful and tumultuous time. So they face what is called the services cliff. And this is where their child stops receiving school-based services. This is often at the age of 21, depends on the state, and they are left without support. So families stop receiving the continuous services that they have been receiving for years. And in fact, this disproportionately affects speech language therapy, which has the biggest drop of all services, including social work, transportation, occupational physical therapy, life skills, mental health services, etc. So I've created this figure based on data from a recent article that surveyed over 5,000 parents and caregivers of autistic children and adults in the Pennsylvania area, though I want to mention that these numbers aren't that different from national rates in 2015. This graph represents different life stages on the x-axis, and the blue line represents the percent of the sample who were receiving speech therapy services, and the orange line represents those who report speech language services as an unmet need. And I want to highlight that at that young adult period is when that percentage swaps. So more people are reporting speech language services as an unmet need relative to the percent of those who are receiving those services. For those who are not SLPs or are not familiar with what SLPs do, these graphics come from the American Speech Language Hearing Association, which is our governing body. On the right, I've highlighted some things that are particularly relevant to the topic today, and some things that you might not think of when you think of speech therapy. So SLPs are trained and equipped to handle things like end-of-life care. They're also trained on cognition and cognitive communication and can work on things like executive functions, attention, memory, etc. Of course, we have expressive and receptive language, social communication, and augmentative and alternative communication, also known as AAC. And then on the left are some stats about autistic adolescents and school-based speech therapy outcomes. So those who receive SLP-directed pragmatic interventions can improve social cognition, social communication, and social motivation by 12 to 25%. They improve their ability to recognize social perspectives of others by 14%, and they have generalized cognitive gains per parent report with about 3 to 12 seeing improvements in working memory, organization, planning, and self-monitoring. Language samples are a really essential tool for SLPs, both clinically and in research. So clinically, they are used in initial assessments to get a baseline understanding of what language is like, and they're also a good method of assessing therapy progress. These language samples can be things like a narrative retell, so retelling the story of Cinderella. It could be a story generation, or it can be a conversation-based sample with either the assessor or with a peer or family member. And these language samples can give us a ton of information across several domains of language, including phonology, which are the rules of speech sounds or how sounds are used. So for example, in English, we don't have words that start with like K, J, P. Like that is not allowed in our rules of phonology in English. And then morphology is the rules of word structure. So think of like adding S or ED to make a word plural or past tense. Syntax refers to the rules of sentence structure. So in English, we typically do subject, verb, object structure. Semantics refers to rules relating to the meaning of language, so what words mean, and then pragmatics are rules that occur within social situations. And then this is a list of different specific things that we can assess with language sampling. So things like utterance length, I'll end up referring to this as MLU, so this is mean length of utterance. We can also get grammatic complexity, articulation abilities, so how intelligible somebody is, narrative skills, imitation skills. We can get so many things from these samples. In the blue box on the right are examples of what an utterance would be. These are different lines here. So the first one is there once was a boy and a frog. And then in the brackets are a couple of different things that we can get from just that utterance. So here we have a story initiation and character identification. And then the next utterance, then he jumped outside the box. We have a cohesive element with then, so connecting two ideas together. We have an instance of past tense with jumped. We have a preposition use with inside, and then an object name with box. So these language samples can be transcribed by hand or in Word documents, but other softwares exist that can extract some of these components of language and can give you, once you transcribe it in that software, can automatically give you numbers about things like grammatical complexity or utterance length. So a couple of software examples are SALT, which is the systematic analysis of language transcripts, and then ChatClan, which is computerized language analysis. So language skills, whether they are spoken language or language through an augmentative alternative communication device, can support learning, literacy, social connection, and self-expression. We know that early issues with vocabulary and grammar development predict later outcomes. So there was one 20-year longitudinal study that followed up on a group of children who had language impairments. And they found that young adults who had a history of language impairments showed poorer outcomes in multiple objective domains, including communication, academics, educational attainment, and occupational status, than their peers who did not have early communication impairments or those who had speech-only impairments, so things like articulation difficulties. So language is critical for the future. I'll also be talking a little bit about Fragile X syndrome today. So I just wanted to give everyone a quick overview for those who are not familiar. So Fragile X syndrome is an inherited genetic syndrome that's caused by a mutation on the FMR1 gene, which is on the X chromosome. So we all have an X chromosome, and we all, at least one, and we all have a CGG sequence repeat length on this gene. So normally this gene, you have about 6 to 54 CGG repeats. And then Fragile X syndrome is when there are over 200 repeats. And that excess of CGG repeats causes a reduction or a cessation in the production of messenger RNA. And therefore, the protein FMRP is absent, and that protein is really important for brain development. So leading to this being the leading inherited cause of intellectual disability. And then in terms of inheritance patterns, if a woman has a premutation, which is that stage before you get to 200 repeats, if they have the premutation on one X chromosome, they have a 50% risk of transmitting that X to their child, which could either stay in the premutation range or it could expand to the full mutation. If the father has a premutation gene on their X chromosome, they wouldn't pass this on to their sons, but they would pass their affected chromosome on to their daughters. So mothers are the ones who are passing the full mutation down. So like I mentioned, it's the leading inherited cause of intellectual disability. It affects about 1 in 3,600 males and 1 in 4,000 to 6,000 females. The majority of males have moderate to severe intellectual disabilities, while most females have borderline average IQ scores, and only about 20 to 25% have moderate to severe ID for females. Most have limitations in their language skills, including challenges with vocabulary and grammar production and comprehension. And it's also important to note that about 75% of males and 25% of females meet diagnostic criteria for autism, and those that don't often have some amount of traits for autism. So Fragile X syndrome is thought to be the leading single gene cause of autism. I'm really interested in studying the overall family quality of life, really from a systems-based perspective. This graphic highlights different individual factors and family level factors that are examples of things that could impact family quality of life. So it's really important to consider the whole picture when we're working with families, and this includes what's going on for family members or caregivers as well. So with parents, there is something called the broad autism phenotype, and this is characterized by traits that mirror autistic traits but aren't at the level where they would receive a diagnosis. So these include things like pragmatic language differences or preference for routine. We also know that first-degree relatives have elevated rates of depression and anxiety, disrupted sleep, limited social support. All of these factors are associated with a broad autism phenotype. And then in terms of mothers of children with Fragile X syndrome, so specifically women who have the FMR1 premutation, they have between 55 and 200 repeats. And typically, if you're the carrier of a gene mutation, you're thought to be clinically unaffected. But in the last 30 years, we've learned that women with the premutation are not clinically unaffected. So they are at risk for things such as Fragile X primary ovarian insufficiency, which is menopause that on average is about 5 years earlier than the general population, and some even reach menopause in their 20s. There's also Fragile X associated tremor ataxia syndrome, which is a Parkinsonian-like disease that is the onset is later in life. And then Fragile X associated neuropsychiatric disorders or FACS-and, and this is characterized by elevated rates of anxiety, depression, ADHD, and autism in women with the FMR1 premutation. There's also been some recent research by my postdoc mentor who's started to look at cognitive aging in mothers with the FMR1 premutation. I want to mention, because this can be confusing, women with the premutation have normal IQ, so there's not an intellectual disability here. It's just some really subtle traits and things that can be serious, like FACS-POI or FACS-TAS. So the first piece of the big picture that I'll talk about today is language. So specifically, language of adolescents with autism and Fragile X syndrome. So there's been a large body of research comparing the phenotypes of boys with Fragile X and boys with autism, and boys particularly because of the genetic sex differences that are linked with Fragile X syndrome. And these groups are often compared to one another because of their similar phenotypes, especially boys who meet criteria for autism. So this helps us understand autism more, understands how autism and intellectual disability interact, and can also help us identify endophenotypes or genetically linked traits that might be associated with the FMR1 gene. So these are just some examples of areas of overlap and distinction between the two groups. So both boys with Fragile X and autism produce perseverative language, so repetitive language, repetitive words or phrases. They also have a similar production of personal pronouns, similar topic maintenance skills. However, there have been findings that expressive vocabulary scores are worse in boys with Fragile X syndrome, and expressive grammar skills are worse in boys with Fragile X syndrome. So this is the first piece of data that I'll talk about. This study, we examined demonstrative use. So demonstratives are words like this, that, these, those, here, there. Typically, developing children use demonstratives early in life, and these are terms that refer to a common referent. In order to produce and comprehend demonstratives, somebody needs to take the perspective of the communication partner in order to create a common ground. So if the demonstrative produced refers to something tangible, the communication partners need to engage in some sort of joint attention to understand the common referent. And if the demonstrative refers to something intangible, such as a previously mentioned topic or something, the communication partner must recognize that the speaker is referring to a formally mentioned topic. So demonstratives really play a crucial role in language and social development. Here I have data on the left for the total number of demonstratives produced during a conversation sample. In the middle is the proportion of concrete terms. So this refers to the proportion of demonstratives that were referring to something tangible in the environment relative to abstract terms, which were referring to like a previous topic of conversation or something. And then on the right is the proportion of appropriate terms. And here appropriate means using that instead of those when referring to something that's singular. So overall, we found that boys with Fragile X and co-occurring autism produced more demonstratives overall, but boys with autism had a wider variety of concrete and abstract terms, whereas boys with Fragile X syndrome primarily produced concrete demonstratives. And overall, we found that boys with Fragile X had fewer appropriate demonstratives. We also found, not pictured here, but that higher mean length of utterance, so grammatical complexity, was related to increased demonstrative production and then fewer errors in demonstratives. And that was in autism in particular. And then in Fragile X syndrome, grammar was only related to the total number of demonstratives. So the errors, the difference in the association between grammar and error production between the two groups could indicate that language ability might not be playing the same role in referencing skills for these groups. A different study that we did is we looked at question asking skills in boys with Fragile X and boys with autism. So this is a overlapping sample from the data that I just showed you. We coded their samples for a variety of different questions. So novel questions, asking a question to learn something new within the activity, personal questions, so asking the examiner a personal question in order to learn more about the examiner. A clarification question, so asking a child to clarify expectations or something the examiner said, echolalic questions, and then informational questions, such as, are we done yet, or what time is lunch? And then duplicate questions, so asking the same question multiple times in a row. We found that boys with Fragile X asked more questions overall, but they asked fewer personal questions relative to the autistic group. Um, Despite asking a large number of questions, the boys with Fragile X produced only about 2% of their questions were personal questions relative to 10% for the group of autistic boys. It's important to point out that both groups also asked primarily novel questions. So asking questions to learn something more about the activity, like where does this go? It's important also to point out that these come from the ADA, so this wasn't part of the conversation sample. So the ADOS contains a variety of play-based tasks and activities. So it's just important to consider that in terms of interpreting personal questions. Like that might not have been a setting where a child would be asking personal questions and might be more likely to ask more novel questions. And then another example of a component of language that we examined from language samples are word errors and utterance errors. So with a similar cohort, we coded for omitted bound morphemes and omitted words. So a bound morpheme is a morpheme that needs to be attached to another word. So that includes things like S to make things plural or re at the beginning of a word. We also looked at word level errors, so errors that were used incorrectly, either semantically or grammatically, and then utterance level errors were coded when there were 3 or more omissions or word level errors in one utterance. So here in this graph, this is just data for the autistic boys. So this we also looked at boys with Fragile X syndrome, and the data is really similar, but I wanted to highlight the autistic boys here. So this is in comparison to a group of typically developing children from a reference database. We looked at children who were matched on mental age and then children who were matched on their grammar skills. And we found that autistic boys were producing more linguistic errors during their language sample compared to both of these groups. So it's important to dig in further to understand how grammar can support these interactions. So these language-focused studies are really important for not only identifying areas of challenge, but areas of strength, and also understanding the co-occurring Fragile X and autism phenotype. Important next steps are examining how language can impact outcomes down the line. So how important are these things like demonstratives when it comes to later outcomes? And then what are the longitudinal impacts of targeting these specific aspects of language? All right, next I'm going to present some data on language in adults with Fragile X and autism. So the first study that I'll talk about included 84 autistic adults, 62 males and 22 females, who were between 18 and 53 years of age. This was part of a larger longitudinal study that had multiple waves of data. At this fifth wave of the study, which I'll call time one, participants or autistic adults participated in a semi-structured interview with the examiner. Whereas the eighth wave of the study, which I'll call time two, is where we got our outcome data, and that was 5 years after. And I'll talk about the outcomes that we measured in a second. So to assess language, we chose two variables that we thought represented more structural language and another variable that represented pragmatic language. So the first variable was the number of different words produced. So not the total number of words, the number of unique words produced during the sample, and that was a measure of vocabulary diversity. And then we also looked at the proportion of elaborate utterances, and this we took as a measure of social communication. So in those language samples, we coded each utterance to be adequate. An elaborate utterance, this is when the participant added or requested significant new information. We also coded for topic changes and inadequate utterances, but since these were all calculated as a percentage out of the total number of utterances, to reduce multicollinearity in the models, we just stuck with one measure, which was the proportion of elaborate utterances. So the first outcome that we looked at was friendships. This comes from the Autism Diagnostic Interview Revised, one question that asked about friendships specifically. So the parents were asked at the present time, does your son or daughter have any particular friends or a best friend? And then based on the information from that question and follow-up probes, examiners determined if the adult had mutual relationships, which was coded as a 0, limited reciprocal relationships, which was coded as a 1, relationships in group settings, which was coded as a 2, or no peer relationships, which was a 3. Here we found that both the measures for vocabulary diversity and social communication were associated with friendships. So more vocabulary diversity was more likely to have mutual relationships, and the same for more elaborate utterances during a conversation. The second outcome that we looked at was vocational independence. We used the vocational independence index, which was designed by Julie Lance-Taylor and Marcia Malik, to look at how language predicted vocational independence 5 years later. Here we found that only the number of different words was associated with vocational independence. So higher vocabulary diversity was associated with more independence. So the difference between the friendships having an association with a proportion of elaborate utterances, but not vocational independence, is possibly because friendships involve conversations which aid in establishing common ground and building the relationship, which would be supported by something like topic maintenance. Whereas success in vocational settings, on the other hand, may not rely on social language skills and instead may be better supported by more sophisticated structural language skills, like having a diverse vocabulary. So these findings really underscore the importance of verbal language skills in adulthood, especially when we consider the sharp decline of services and the number of autistic adults who are receiving speech language services after school. Also, I see that my camera's glitching. I don't really know what to do about that, so we'll just leave that. Okay. The next study that I'll talk about examined predictors of self-determination in young adults with Fragile X syndrome. So self-determination refers to setting goals and making decisions about one's own life with supports in place as needed. The development of self-determination can support self-advocacy, which not only impacts participation in transition planning, but also promotes community participation and the development of a positive self-identity. This table comes from this paper. So we had 36 males with Fragile X and 9 females with Fragile X. all between the ages of 17 and 25. Down at the bottom are our outcome measures and our predictors. So self-determination was assessed using the AIR self-determination assessment, which was completed by the caregiver. And this yields 3 scores. So one for capacity, which refers to like abilities and knowledge to be self-determined. And then opportunities at home and opportunities at school are the 2 other scores that you can get from the AIR. So in this questionnaire, parents use a Likert scale that ranges from 1, which is never, to 2, which is, or 5, which is always. And there were 6 items per subscore. So they rated items regarding their child's capacity for self-determination, which includes items like my child knows what he or she needs, likes, or is good at. And then questions about opportunities at home. So at home, my child is allowed to act on his or her plans right away. And then opportunities at school, which is the same thing, but at school, my child is allowed to act on his or her own plans right away. So higher scores represent greater capacity and more opportunities for self-determination. And then our predictors of interest are at the bottom here. So we have the violent adaptive behavior as a measure of adaptive behavior, the expressive vocabulary test as our measure of language, and the social responsiveness scale as our measure of autism traits. We found here that language actually wasn't a significant predictor for self-determination, but we found that adaptive behavior was predictive of self-determination capacity, so the knowledge and skills, and autism traits were associated with opportunities at school. And specifically, when we took the SRS and looked at the subscores for social communication and interaction and restrictive and repetitive behaviors, it really was the social communication and interaction component that was predictive of the opportunities at school. So these findings have implications for practice, such that interventions that target adaptive behaviors and self-determination could be an effective approach for promoting autonomy and independence for young adults with Fragile X. And additionally, caregivers and educators should continue to provide opportunities to practice self-determination, regardless of their perception of capacity, regardless of whether the child has increased autism traits. It's important to continue to provide those opportunities with supports as appropriate. Okay, the next study that I'll talk about for autistic adults, language of autistic adults, is a study that we just recently published a few months ago on filled pause production. So filled pauses are thought to be a quantifiable linguistic indicator of pragmatics. So filled pauses are things like and They're often considered to be a component of disfluency, so interruptions to the flow of speech, but there is research to suggest that filled pause use does have a listener-oriented function, where speakers use them to inform the listeners about the certainty of their message, to signify that the speaker is searching for what to say, or to indicate that the speaker intends to hold the conversational floor during interactions. There's also differences in versus So often signals an upcoming long delay, while signals an upcoming short delay. This study included 10 female autistic adults and 33 male autistic adults who were in a transition-based program. Here, they were asked to provide a 5-minute speech sample. Some of you might be familiar with the 5-minute speech sample. It's traditionally used to assess expressed emotion for parents talking about their child. But here, the autistic adults were asked to talk for 5 minutes about their parents and their relationship with their parents. And now I'm very cognizant of every time I say and So we found that the rate for autistic adult males was higher than females. And the ratio was higher for males than females. And the ratio is the calculation of plus no, over plus So the percent of out of their total number of disfluencies. So these findings are similar to findings that have been reported for children by Parrish, Morris, and colleagues in 2017. And it also mirrors patterns observed in the non-autistic population, where males produce more uhs than females. However, results from non-autistic speakers indicate, well, like males do produce more uhs. The variance between the groups is similar, whereas here there's a lot more variance for our male participants than our female participants. So we had male participants that were producing 0% and then male participants that were producing 100% instead of So it's unclear what is underlying the wide range of filled pause use in autistic males, but this finding does reflect the inherent heterogeneity that we see in autism. Parrish, Morris, and colleagues also, their sample was 6-year-olds to 17-year-olds, and they also included non-autistic children. And they found that the production of ums and uhs for the female autistic children was similar to the filled pause production of their non-autistic peers. And they posited this to be sort of a linguistic form of camouflaging. So this was not something that we were able to do because we did not have that comparison sample, but I think it's really interesting to think about linguistic camouflaging and what that can look like for females. So for research in language of adults, the ultimate goal for this is to inform the trajectory of language skills after adults stop receiving school-based services, so we can really inform what are the consequences of that services cliff within speech-language pathology. It's also important to identify how language is tied to outcomes and then develop and implement adult-focused treatments. We know that from other studies in intellectual disability that language is malleable. Language does not stop developing once you hit 21 or stop receiving school-based services. So understanding what is a functional treatment that is evidence-based that can work for adults is an important next step here. The final thing I'll talk today is about, is parental phenotypes. So I've been a part of a couple within family language studies. So one is in that filled pause study that I just talked about. We also looked at filled pause production of mothers and fathers. So these within family studies of pragmatic language differences can potentially inform genetic liability. There have been other studies that have found associations between autism traits in children and pragmatic language features in parents. But these do seem to be dependent on gender. So a recent study found that primarily pragmatic language in mothers was related to social communication skills in children, while paternal rigidity was related to child repetitive patterns of behavior and reciprocal social communication. So the study that we did included 40 moms and 15 dads. So there were 29 mother-child pairs, 2 father-child pairs, and 11 father-child triads. And the ages for the parents were between 41 and 62 years. So we found that adult ratio was associated with mother or rate and ratio, whereas adult child rate was associated with father rate. So this the variation in field pause use is posited to reflect aspects of pragmatic language ability, such as communication reciprocity and signaling for the listener, but they also might reflect cognitive processes like word finding difficulties. But it's not clear what language processes are reflected in our findings here. Another study that looked at within family language looked at mazes. So mazes are disruptions to the flow of language. So these include filled pauses like and but also things like word repetitions or sentence revisions, which reflect difficulty with planning your language. So we had 26 children, autistic children, 29 children with Fragile X and autism, and their mothers who participated in this study. And we found that mazes were correlated within the Fragile X dyads, and maternal mazes were correlated with only child perseverations within the idiopathic autism dyads. So there's a couple things to consider here. So this was also taken from the 5-minute speech sample. So contains several different cognitive and language skills like planning, self-monitoring. So from this perspective, reduced use of mazes could result in misunderstanding or lack of clarity in a message, but maze use has also been linked to executive functions. So increased rates of mazes may reflect deficits in things like inhibition or planning. So taken together, it might be that the aspects of maze production may be related to pragmatic language and executive function. So those were some examples of within family language studies, but what I'm going to focus on next primarily focuses on mothers of autistic children and cognition and mental health. We know that mental health for mothers of autistic children, specifically rates of depression and anxiety, are higher in mothers relative to mothers of typically developing children. This is a study that we recently published. It was a COVID-focused study, but we found that over half of our mothers of autistic children scored above the cutoff on a depression questionnaire and an anxiety questionnaire. And so those are higher rates than what we saw for our mothers with the FMR1 premutation and the mothers of typically developing children. So as we know, mothers can experience increased stress that's prolonged and can stay with them as they age. So I was curious if there was a risk for accelerated or atypical cognitive aging because of this prolonged stress. So I received an F32 from the NIA to look at this, to use a full neuropsychological battery to assess cognition in mothers of autistic children who are 55 to 75. And this really has become an area of interest for the National Institute on Aging in particular. And actually, it turns out I was onto something. This study was just published a couple months ago, and it used a cohort of millions of people from Sweden, and they found that there was risk for dementia among parents of autistic children compared to aunts and uncles and grandparents. And the strongest risk was actually for mothers compared to fathers. So this could be indicative of a potential genetic link, because we know that there are higher rates of dementia in autistic individuals, but there could also be environmental factors at play. So this proposal, this study was grounded in a framework called the diathesis stress model, which suggests that the interplay of genetics and environment can influence cognitive aging. So diathesis, the predisposition for illness, there are higher rates of dementia in autism. We know that autism is heritable. Perhaps there's an increased risk there. The stress component are all of these things that are known risk factors for dementia. So increased rates of anxiety and depression, poor sleep quality, continued caregiving, low levels of social support, and the combination of these two might increase risk for dementia or atypical or accelerated cognitive aging. So I'm going to present some preliminary unpublished data from my F32. The first thing I'll talk about is some self-report memory data. So this comes from the Memory Functioning Questionnaire, which is a 64-item survey that assesses everyday memory and forgetting. We also looked at the effects of sleep, which is a known risk factor for dementia, and the broad autism phenotype traits as our index of genetic liability. So we found that within mothers of autistic children, elevated broad autism phenotype traits and poor sleep quality were each associated with worse subjective memory. So both an environmental factor and a marker of genetic liability here. And then we were also interested in seeing if sleep quality could mediate the relationship between broad autism phenotype traits and subjective memory, because we know that those with the broad autism phenotype are more likely to have sleep issues. So we did find a significant indirect effect of broad autism phenotype traits on subjective memory through sleep quality, which suggests that the broad autism phenotype traits are associated with worse memory, partly because these traits lead to poorer sleep. So poor sleep quality is a significant mechanism through which the broad autism phenotype negatively impacts memory. So this suggests the direct effect suggests that the broad autism phenotype symptoms on memory suggest that beyond sleep, genetic liability could directly contribute to memory challenges too. So a focus on improving sleep might help reduce cognitive difficulties in individuals who exhibit the broad autism phenotype. And the last piece of data I'll show here comes from a more objective measure of memory. So we used the NAC Universal Dataset Battery, which is a full neuropsychological battery that assesses all aspects of cognition. And there are published composite scores. So we use the memory composite score, which contains scores from the Craft Story 21, which is a short story that the examiner reads. The participant is to repeat that story as accurately as possible immediately, and then after about a 15-20 minute delay. And then those get scored in two different ways. The score that counts here is a paraphrase scoring. So it's a more lenient scoring. So the first line is Ricky was playing ball. If they say Ricky, that counts, but if they also say there was a boy who was playing a ball, that also gives them points. So as long as they're really getting the gist of the story, they would have a higher score. The other component here is a Benson figure copy task. So this is just a black and white abstract shape drawing that they see and they draw themselves right away. And then they're asked to draw it from memory about 15-20 minutes later. And so that delayed recall score goes into the memory composite score here. And we were interested in looking at loneliness. So we used the UCLA loneliness scale, which is a 20-item scale designed to measure one's subjective feelings of loneliness as well as feelings of social isolation. And we found that mothers of autistic children were affected by increased loneliness. So there was an interaction effect here where increased loneliness was associated with worse memory composite scores for mothers of autistic children, but not for our control mothers. So these were mothers of children who didn't have any diagnosed or treated developmental disabilities. And as a reminder, this group is 55 to 75 years old. So our results suggest that mothers of autistic children might be adversely impacted by increased rates of loneliness, such that moms who perceive more loneliness might be more likely to perform poorly on memory tests. And so although we also looked at a couple other composite scores, so executive function, visuospatial, and language, and we did not find differences there. So future research really needs to dig into this a little bit further in terms of longitudinal data to track these components over time to inform age-related trajectories. I talked about language samples, so this is still to come. I collected several different language samples from this group, including things like the cookie theft picture, which is on the left, where they're asked to tell a story about what is happening. The Cinderella story in the middle, where they get shown the pictures from the Disney book of Cinderella without words, and then they put the book away and retell the story. And then a task called the Trip to New York task, which is a 5-minute um, exercise where they're asked to tell the examiner about their plans for a 2-week trip to New York City. So, how they will get there, things that they'll bring, what they will do when they're there. Um, I'm excited to dig into this because there have been some studies by particularly Kim Mueller at University of Wisconsin-Madison, where she found that language can predict who goes on to develop mild cognitive impairment, which is the transitional stage between healthy aging and dementia. So I'm really interested to dig into these language samples and look at specific aspects of language and what might be associated with the neuropsychological battery scores. So it's really important to continue this work on caregivers, given that this can impact the family quality of life more broadly. So, if parents are having memory issues, bigger issues like navigating the service cliff or coordinating future care for their adult children might be more challenging. It's important to also continue to tease apart genetic risk versus environmental factors since there are so many things at play here. And then finally, I think identifying how to intervene for caregivers and determining what is the best time to intervene and what does the intervention look like because um, we know that mothers typically aren't thinking of themselves when they are caregiving long term for their child. So, determining that and what those next steps could look like is a really important future direction. I'd like to acknowledge, of course, the families who participated in the study, and then my postdoc lab and mentor, Jessica Klusek, and then my PhD mentor, Audra Sterling, and her lab, as well as my many mentors and collaborators and funding sources. And I'm happy to take any questions.
Thank you very much, Laura. This was just a really great presentation. A really interesting body of research on families, and I think
Mhm.
really on language too, of course, of people with Fragile X and autism, and then on families and the impact on family caregivers, and kind of I feel like kind of taking that caregiver research a little further along, in terms of understanding that impact on potential dementia or other kinds of outcome issues for caregivers. Yeah, so we can open it up for questions. And I can start off with a question just in terms of your new study that you're doing right now. Are you recruiting from Texas?
So I have mostly finished my autism sample. So my goal was 60, and I have 56 right now. So I am using some startup funds to fill out that sample a little bit more, but I am still recruiting control moms. So I have about 30 more to go for those. So I will be recruiting from Texas for that.
Great. Yeah. Um, other questions that people have?
We do
There,
have,
yeah, go ahead, Caroline.
oh, I was gonna say we have a couple in the Q&A. Um, okay, one is just asking if you can share the flyer for recruitment.
I would be happy to. I don't have IRB approval here yet. So once I do, I'll connect with Caroline and
Mhm.
hopefully get that disseminated.
Yeah, I can send it out to our attendees or Jasmine, you specifically. Thank
Mhm.
you. And then we have a question from Beverly. What was the age range of the sample? And I know there were lots of samples. I'm not sure if
Mhm.
they're able to remember at what point. This
Yeah.
was the
And
beginning
this was
half, so it was
yeah.
probably one of the children or youth.
Yeah, this
Yeah.
was at 12:22, so you can get an idea when you were like
Most
20 minutes in when
Yeah.
talking about.
So the first three studies where we did adolescents, they were between 9 and 18. I'm pretty sure. It might have been 9 and 17. The autistic adult sample was 18 to 53, and then the self-determination was uh, 17 to 25. So you're probably asking about the first sample where I didn't present the ages. So
Mhm.
that was 9 to 17 or 18.
Yeah.
Yeah. And I also have a question about your research on mothers. Was there any I guess gathering of data on if any of the mothers were autistic?
I There are many things that I'm looking back on now that I should have collected that I didn't collect, which I guess is just sort of the research process, isn't it? Um, but no, I don't have that data. I did collect the broad autism phenotype questionnaire from them, so that will give some insight. They also filled out a health history form questionnaire, so I can look at that to see if they reported any diagnoses there. But no, that's not something that I asked directly, but I should have.
Yeah. I'm wondering if the broader autism phenotype, if anybody's tried to create like a cutoff that would indicate autism, that would be another.
Not that I know of. I know that
Mhm.
there are cutoff scores for the broad autism phenotype, but yeah, I'm not sure about how that relates to other autism measures and whether there's a cutoff that exists for it. I don't think there is.
That's another study we do. Yeah, we could, but anyway, yeah,
And we have a raised hand from Jeanette.
great. Are you able to allow her to speak?
Let me see real quick. While I figure that out real quick, we have a question that says, "Isn't there a genetic factor in autism?"
Yes, there is. There have been several studies that have looked at genetics and have identified, I think, like 400 autism-related genes. We know from twin studies that there is a genetic factor in autism. So, yes, there is a genetic factor there.
All right, Jeanette, I'm gonna allow you to talk. All right, you should be able to ask your question now.
Oh, that was the same question. But my second question I
Okay.
have is regarding participation. I can see in African American was 0% and
Mhm.
13%. And I'm wondering it's because those community doesn't have autism or it has been denied it. So because there is from my perspective, so we do have different myths, if I can say that, so which is guided by our culture and beliefs. So some we don't even believe or accept that autism exists.
Mhm.
So and we are giving another label from culture and beliefs where we call it we call it witchcraft. So is that maybe there was no one responded or as African American community?
Yeah, this is a really great point that you're bringing up. So I have talked to families who have brought up that witchcraft belief to me. And I do think that it does play a role in terms of who's participating in research and who goes to get diagnosed.
Mhm.
Um, the most recent CDC report did report differences in race in terms of who is getting diagnosed. I think it was lower income families and Hispanic families in particular that were less likely to be diagnosed. And I can't remember if there was a difference for African American families versus white families. I also think it's really region based. Cindy, do you know?
Yeah, the most recent CDC study actually shows that Black children are diagnosed more than white children now. It used to be either less or the same as, and even Latino children are not being in the most recent data being underdiagnosed anymore. They're trending towards being more diagnosed than white children. So actually, children are being diagnosed, and there are a lot of research studies that do include African Americans that have a lot of, they do talk about cultural issues that are distinct for sure, and that's super important to explore.
Will you allow me to add comments on your comments again? On Sandy's comment?
Oh, you want me to repeat?
No, I wanted to comment on it
Oh,
again.
yeah, 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 yeah.
So, my comment saying that nowadays, the autism is really popular in African American kids. So, I think it's the way the diagnostic has been performed or evaluated, because we do see the issue in different lenses. So, where what you call normal, it's what we call normal, it's what we call abnormal. So bringing our kids here, it has been challenging. One, our kids has been like elevating outside the home, no kids being at home from morning to the evening. So they're outside playing with friends, playing with neighbors. So coming here, they find themselves in one small room in front of a TV and technologies, tablet and everything. So they just lose their comfort zone and they're starting behaving differently. So when you see that here, you start saying, these kids they must have HDL or they do have another behavior, but it's kind of changing their culture where they used to play outside. Honestly, going back in Africa, the houses are open. The door is open, the window is open. So kids never be inside the house till it's time for eat or time for sleep. Otherwise, they're running up and down outside with their friends and neighbors, which is totally different when they change life to coming here, where they have to face a small square meter to look only on TV and then starting like absorbing other culture, other behaviors. For them, it's like kind of trauma. And then they don't do like differentiation between those incidents. They just label them as autists. So I would like to recommend maybe for future time when they do this kind of research, they have to include also the culture and also the languages barrier. So where people they're not able to explain themselves what they face, and also to do more awareness on that so people they can know what they have to look on Black and African kids when they do diagnostic for autism or trauma.
Yeah.
Thank you.
Yeah, thank you for sharing. Another thing that I want to mention here, this table is for the study on boys with or young adults with Fragile X syndrome, both males and females. Um, Recruiting a non-white sample in Fragile X syndrome is particularly challenging.
Yeah.
A lot of the families that get recruited to do studies um, are plugged in to the National Fragile X Foundation, and their listserv is primarily white. This has been a problem that has been documented in Fragile X syndrome research. I think I went to a talk a couple of years ago that stated that like the large majority of studies in Fragile X syndrome don't even report race in their
Mhm.
studies, which is a huge problem.
Mhm.
So this is something that the Fragile X research community is very aware of and is working hard to figure out how to get our samples to be more representative. But yeah, it's a really important issue that we're facing here.
Totally agree. Yeah, and I think a lot of because Fragile X is something that's diagnosed with a genetic test
Mhm.
versus autism, which is behavioral, right? So, um, one of the challenges could be that people from different communities are not getting that genetic test for one reason or another, whether they're not aware of it or whether their healthcare providers are not suggesting it. There are a lot of different reasons that that could be.
Yeah.
Yeah, and speaking about genetic testing, we have a question that asks, would you recommend genetic testing for parents of children with ASD?
Um, I'm not a geneticist. I'm a speech therapist. So I right now I would say probably I'd like to hear your opinion, Sandy, but I would say probably not. I don't think there's enough that we know about the genetic basis in autism. I think if your child gets diagnosed with Fragile X syndrome, it's important for um women to know what their CGG repeat range is. So doing a genetic test if that's the case. Um, is important, but I'm not sure if there is a push for parents to get genetic testing if their child's autistic.
Well, okay, I have an opinion about that, but Dr. Brumbeck, many of you know, she's a pediatric neurologist here. She actually has been recommending genetic testing for all the kids that come in for a diagnosis of autism. And part of that is not just Fragile X, but because they are discovering more and more gene combinations for autism now. The majority of kids with autism, they probably have, I think it might be up to like some people say 20-30% of kids might have some genetic, findings related to autism. So it's worth trying to, I mean, because if there are genetic findings, that does help the parents, understand a little bit better. And we can also detect, I think particularly in underserved populations, I think it's important to do as well. That's just from the perspective of like identifying more people with Fragile X, because there are kids who have a diagnosis of autism who may have Fragile X, but they don't know it, because there is that co-occurring incident. So, yeah.
Yeah. And we have another question. What recommendations do you have for mothers of autistic children to reduce risk for early cognitive aging, and how early is the concern?
In terms of how early the concern is, we really don't know yet within this specific group. This is really new research that's been coming out. In terms of reducing risk for early cognitive aging, I would look at what has been published from aging research. So, prioritizing sleep, exercise, diet, making sure you have a social support network, doing those things um, that are known to help with aging and healthy aging, I think would be an important suggestion for mothers of autistic children. I also want to point out that that Swedish study, the risk factor wasn't humongous. It was significant for mothers of autistic children, but it wasn't like they weren't like 10 times more likely. I think it was, I don't remember I don't want to make up a number,
Mhm.
but it wasn't at a point where it was super significant. So I also don't want to be fear mongering here,
Mhm.
and saying that this is a known um, area or known uh, thing for parents to be concerned about. But yeah, I would recommend following what we do know about promoting healthy aging, especially knowing that mothers of autistic children do have those risk factors like low social support or work sleep. So doing whatever you can to address those, I think would be important.
Yeah, thank you, Laura. And then we have maybe a comment here from Stephanie. I, psychologist, recommend genetic testing for parents because there are some rare genetic disease communities that provide parents with support networks for unique ASD presentation. And then they also said, I believe that AAP has also recommended it. So thank you, Stephanie.
Yeah.
And then we do
Great.
still have a little bit of time if there are any other questions out there.
Mhm.
And I will quickly note that if you registered and requested a CEU, that I will email you next week with a link for you to receive a PDF copy of that CEU. Looks like Jeanette. Let's see. Sorry, I might have to. Um, is it something you? I think I.
Yeah,
Oh,
no,
there we
I'm
are.
unmuted. So I have a question for Laura. Will you mind to share this research, like with the group or personally with me?
Um, yes, I'd be happy to. I
Yes, and
know
thank
that
you.
this presentation does get posted, so you'd be able to refer back to it.
Mhm.
Um, but yes, I can get your contact information. I think it does, Caroline, does it come up with registrants?
Yes.
Okay, I'd be happy to share the slides with you if you'd like.
Thank you. It's very useful.
Yeah.
Thanks.
Yeah, and Laura, if you want, you can send me that copy and I can send it out, or I can email you the email, whatever works
Okay,
out. We can be in contact about that.
Yeah.
sounds good.
Yeah.
Great. Well, thank you so much. It's super important research. And yeah,
Yeah, thank you all.
everybody have great holidays over the next few weeks. So, and then we'll see you. I don't know if we actually do we don't have anything in January, right?
We do. We
Oh, we
do
do.
have a consortium in January. I believe the 26th of January, but
Mhm.
be on the lookout for that flyer.
Do you know
Uh,
what the topic is?
not off the top of my head. I know
Oh,
it will be Dr. Hampton, um, and
okay. Great.
Hannah Phipp. Um,
Yeah. And they do early intervention, so it'll probably be on that topic.
yeah, absolutely. All right. Thank you, everybody, for joining us today. We're gonna go ahead and end a few minutes early, give you some time back.
Yeah, great. Bye,
All right.
everybody.
Thank you. And thank you, Laura.
Yeah, thank you.